Here we're viewing the rotator cuff from posteriorly. This is a large tear. To the left of our probe, you can see the rotator cuff tissue, which has clearly been torn away. On the right is the bone of the humeral head, also known as the footprint of the greater tuberosity, which is the normal attachment site for the cuff. Next, we come with the tissue grasper, evaluating the mobility of the cuff. You can see we're grabbing on it, pulling this L-type shaped tear anteriorly as well as the tear laterally towards normal insertion point. Next, we come in with an arthroscopic burr to gently debride the cortical bone, establish some bleeding bone, as well as to remove any further soft tissue at the attachment site of the rotator cuff. Once that's completed, we are now placing a biocomposite anchor. So it's a type of material that bone will actually grow into and around, so there's no metal involved. We place one anchor in toward the front of the shoulder anteriorly. We then drop a second anchor posteriorly based on the size of the tear. Again, this would be classified as a medium to large tear. So an anchor is inserted. On the back of each of these anchors are 4 sets of sutures. We then have an instrument that's able to take the suture tails, which you're seeing here, and then pass it through the rotator cuff. Knots are then tied medially, completing our medial row repair. Again, here you see the cuff tissue, the knots of which are on top. It has now been reopposed to the footprint or the greater tuberosity, and what we call a single row repair. We then retain the suture tails and incorporate them into a second set of anchors, completing what's called a double row rotator cuff repair. Here we see our knots tied medially with the suture tails retained in a lateral row of anchors. We increase not only the footprint size, so not only the restoring the anatomy of the native rotator cuff, in addition it provides for more biomechanically stable construct. Now we look at our finished product from posteriorly. We gently range the shoulder. We see that our cuff repair is stable, certainly stable enough to start an early range of motion, early physical therapy. And then we once again evaluate the cuff from laterally, looking at the junction between the bone and the cuff. We then take the arm through a gentle range of motion. We see that there's no gapping between the cuff and the bone. Once again, certainly allowing us to start an early range of motion for this large rotator cuff tear. Thank you.